Welcome to Horizon Medical Education Podcast, concise, evidence-based audio lessons for clinicians worldwide. For supporting notes, accreditation, certificates, and access to all our courses, visit our platform at www.horizonmedicaleducation.com. And just as a reminder, this podcast is intended for medical professionals and for educational purposes only. It does not replace clinical judgment or local guidelines. Episode 4, Ebola Disease Part 2.
I'm Fran.
And I'm Minnie.
And as always, please do give us your feedback.
So our tip today is, with every medical procedure, ask yourself, will this benefit the patient? And can it be performed safely while minimising exposure risk to healthcare workers?
Gosh, that's so important, isn't it, Minnie? Thank
Definitely.
you. As you said, this is part 2, and we are going to discuss investigations, screening, and management. And Minnie, let's just remind ourselves why we're talking about Ebola. There are 3 different viruses that are known to cause large Ebola disease outbreaks. There's Ebola virus, Sudan virus, and Bundibugyo virus. This latter one is the cause of the current outbreak in 2026, when we're recording this, in the DRC and Uganda at present.
Yeah. The average Ebola disease case fatality rate is around 50%, so it's a very serious infection.
And early intensive supportive care with rehydration and the treatment of symptoms improves survival. So it's really important to catch these patients early.
And outbreak control relies on a package of interventions. So this includes intensive supportive care of patients, infection prevention and control, which is obviously extremely important, disease surveillance, contact tracing, laboratory services, safe and dignified burials, vaccination if relevant, and social mobilisation.
Brilliant. So let's start off on our first topic, which is investigations. And one of the first things we need to do is to diagnose whether this is Ebola or not. When managing an Ebola outbreak, laboratory testing serves 2 main purposes: confirming active infection and also supporting surveillance or epidemiological investigation. There are 4 main diagnostic methods. These are reverse transcriptase polymerase chain reaction, or RT-PCR, and that detects viral genetic material.
Then there's the antigen capture detection tests, which we all are more familiar with, thinking of them as antigen rapid diagnostic tests, and these detect viral proteins. And we also know them as lateral flow tests, and obviously they were very common during COVID.
The third test is an antibody capture enzyme linked immunosorbent assay, or an ELISA test, which detects the host immune response.
And finally, virus isolation by cell culture, which detects live replicating virus. And this is more used for identifying strains, looking at the genetic material of viruses.
Yeah, so going back to what you were saying earlier, just remember that samples collected from patients are an extreme biohazard risk. On non-inactivated samples should be conducted under maximum biological containment conditions. All non-inactivated biological specimens should be packaged using the triple packaging system and when transported nationally and internationally.
That's so important, isn't it?
Yeah, gosh.
The WHO has got quite a lot of good resources on this.
And I think this is true about all sort of biohazardous materials, isn't it? Because I know that very, very rarely there's like an outbreak of the plague or even smallpox where it's a laboratory worker who's been testing it, who's actually caught it. So, you know, it's so important to keep those people safe.
Yeah, quite, it's a risky job, isn't it?
Gosh. It's so risky, yeah.
Okay, so let's have a look at the 2 main testing for acute infections. So we're going to first of all look at reverse transcriptase polymerase chain reaction test, and Ebola is diagnosed using this to detect the virus's RNA in whole blood or plasma. Now, this is the gold standard diagnostic test for acute Ebola infection. And RT-PCR targets specific genetic sequences of the Ebola virus, such as the NP gene or the L gene. Testing is only performed on symptomatic individuals who meet the case definition of Ebola disease. And the results are positive for species of ortho-Ebola virus RNA, for example, the ones that we've talked about in part 1, the ortho-Ebola virus Zairinizi, ortho-Ebola virus Sudanese, and the ortho-Ebola virus Budibunjurinizi.
So there are several different commercial PCR tests available, and they have varying sensitivity, specificity, and limits of detection. Let's just do a quick explainer here, because it's something that we all learned, and if you're anything like me, we all forgot again. Sensitivity and specificity are expressed as probabilities. Sensitivity is the probability of a laboratory test being positive if the patient has the disease in question. And specificity is the probability of a laboratory test being negative if the patient does not have the disease in question.
Fantastic. That's really helpful. Thanks, Fran. So going back to our PCR kits, the testing is highly regulated and usually restricted to reference or specialised public health laboratories due to biosafety protocols, obviously. In epidemic settings and some countries, Category 4 laboratories are set up locally and results are available 4 hours after the sample has arrived. And this is all very much to keep everyone safe with such an infectious disease.
Viral RNA can be detected in the patient's blood by RT-PCR from day 3 up to days 6 to 17 of symptom onset. A positive PCR result implies that the patient is potentially infective, particularly if he or she has active diarrhea, vomiting, or bleeding. And we know that higher viral loads correlate with adverse outcomes and increased mortality. We learned that, didn't we, Minnie, in part 1?
Yeah. Fran, if the test is negative and the blood was drawn less than 72 hours after symptom onset, then you should repeat the test with the blood drawn more than 72 hours after symptom onset. So, for example, if someone's presenting to you sort of 48 hours after they've started with symptoms, you then need to leave it another 24 hours, which takes you to 72 hours after symptoms have started, to then take another blood test.
Got you. Okay, yeah. And that's because the viral load can be low and undetectable in the early course of the illness. Yeah. Equally, a negative test should be repeated to rule out a diagnosis if clinically you strongly suspect them to have Ebola.
Yeah. The RT-PCR is also used to confirm recovery, and patients are typically cleared for discharge following 2 consecutive negative PCR tests taken at least 48 hours apart. So even once you've recovered, you're still going to be in isolation until your 2 PCR tests have come back 2 days apart.
Goodness me, yeah, so 2 further days isolated. The second test that you mentioned, Minnie, this is the antigen rapid diagnostic test. These are lateral flow tests, and they use a finger prick of blood, saliva, or cadaver swab to detect Ebola viral antigens on a simple testing strip. Like you mentioned, we used them during COVID, didn't we? And they are a form of antigen capture detection test. The Quick, that's a trade name, Ebola Rapid Antigen Test, which was developed with CDC, is one of the most widely recognised and can provide results in about 30 minutes. So an awful lot quicker than the 4 hours, isn't it?
Yeah, definitely.
Rapid diagnostic tests are currently being utilised in the active Ebola outbreak, which we mentioned earlier on, primarily for rapid triage, community surveillance, and post-mortem testing.
Yeah, it's because these RDTs can give you such quick results in minutes rather than hours that they're incredibly useful for identifying suspected cases, particularly in remote areas with limited laboratory infrastructure. They're highly specific, and that's reducing the risk of false positives, but have a slightly lower sensitivity compared to lab testing. So because of this, it's really important that if you have a negative RDT in symptomatic patients, that you go on and do a laboratory testing to confirm that it is in fact negative.
So the advice that we have is that these rapid diagnostic tests are really useful, but with several caveats. WHO and public health bodies do not recommend RDTs to replace routine lab testing where molecular options exist. So if you can test with the lab, test. Yeah. Because they have lower sensitivity and specificity compared to molecular testing, any RDT result, whether positive or negative, should then go on and be confirmed with the RT-PCR. In regions without established laboratory networks, RDTs allow local healthcare workers to quickly isolate individuals who test presumptive positive, and that can curb the potential transmission chains before a definitive PCR is returned. So they are, like you say, incredibly useful. Yeah,
it's a two-pronged approach, isn't it? Because you're, one, wanting to identify a patient so that you can get on and give them supportive care, but 2, you're also trying to prevent this onward transmission of the disease.
Yeah, absolutely. And it is a really evolving field. Different kits are approved in different countries and different settings. So you need to follow your local guidance with which you are using.
The WHO have produced in December 2024 some interim guidance for diagnostic testing, which actually also covers Marburg as well as Ebola virus. And we've put a link on the transcript, and it just runs through sort of the indications, sample types, transportation, and the interpretation of results at different stages of the disease as well. And it's really good, recommended reading if you're needing to interpret these results. So in practical terms, RT-PCR is best diagnosing acute infection, and it's your primary outbreak diagnostic tool. The antigen capture tests, well, these are rapid detection of active infection, and they're useful for screening and field deployment.
The antibody capture ELISA test, we didn't go into detail with this, but this detects immune response and is useful for surveillance, retrospective diagnosis, and survivor studies. And then finally, viral isolation by cell culture. So you mentioned this briefly, Minnie. So this is mostly a research and characterization tool, rarely used for routine patient diagnosis because of the biosafety requirements.
Fantastic. That's the investigations. And now we want to think about screening, because obviously in an outbreak, finding active cases is really important. We do this in order to avoid and stop an epidemic as late diagnosis delays effective patient isolation, and then as I was just saying before, it allows for potential transmission of the infection amongst contacts.
Our early diagnosis really hinges on identifying these patients who are at risk, doesn't it?
Yeah.
Case definitions have been developed by WHO and CDC, and they are, and we mentioned this again in part 1, based on the history of exposure, as well as clinical evidence of illness, typically fever, but also possibly headache, myalgia, etc. Within epidemic areas, history of exposure is less useful because many more people will have been at risk. We've got some links to case definitions from the WHO and CDC below, so if you're interested, please do click on those links.
Screening for these patients ensures quick identification of potential cases, and then obviously the need for immediate isolation and investigation. People who are asymptomatic but have epidemiological risk factors may need monitoring, and this will be things like twice daily temperature readings for the duration of the incubation period of the disease and depending on their risk exposure. And this is really to ensure, your rapid recognition of symptoms followed by immediate isolation. And you've put on a nice little infographic there of what to do in various circumstances when a patient presents, haven't you, Fran?
Yeah, we won't. I don't think we'll talk through it, but please do have a little look. And interesting, Minnie, during coffee yesterday with my colleagues, we were talking about what to do with the patient that has a suspected infectious disease, because obviously we don't want them sitting in our waiting room.
Yeah.
And we're explaining to the new doctors and the trainees how we don't let them into the building until the doctor's ready to see them, and then how we let them in the side door. And if we're very worried about infection, then there's a particular room that we use. Unfortunately, it is one of the doctor's rooms, but his is the room nearest the exit.
They've got the best immune system, have they?
Yeah. No, I mean, obviously we would clean it afterwards. But, I was saying that this is really important. The trainees, obviously we don't have Ebola in the UK, but, for other illnesses, for example, you don't want children with chickenpox sitting in your waiting room if you have patients who are having chemotherapy, for example, coming for their blood. So, it is really important that we're mindful of when we triage patients, and however you do that. So in my example, I'm doing it by phone, but you may be doing it in other ways. Then immediately, as soon as you think there may be a risk, you do something about it and isolate the patient to protect them, but also protect your other patients and your healthcare workers.
Yeah. And that's really interesting. I think probably the triage system has helped identify that more than just people turning up and sitting in the waiting room waiting to be seen with all sorts of different things.
Yeah, no, I think it's been incredibly useful. Yeah. Minnie, now we've diagnosed our patient with Ebola, let's look at the other investigations that we would be doing. Firstly, we want to do malaria testing. So this is really essential. Co-infection does occur up to about 5% in patients in previous Ebola outbreaks.
You're going to be wanting to monitor their urea, creatinine and electrolytes to assess for dehydration and acute kidney injury. And we know this is a common consequence of severe diarrhea and vomiting.
If possible, you would check their lactate. So this is a useful marker of tissue hypoperfusion and is an indicator of shock. Elevated levels can help identify critically ill patients with signs of sepsis to identify the degree of systemic hypoperfusion and to guide fluid resuscitation.
Full blood count. This may show various different things, so we'll just go through these. In initial stages of infection, you may see a marked lymphopenia and thrombocytopenia, so that's decreased platelet count. This isn't diagnostic of anything at this stage. Often, after the initial stages of infection, this will be followed by a neutrophil leukocytosis, and this is often seen in later stages of patients who eventually recover, along with a normalization of their thrombocytopenia. So you know, when you're doing your recurrent testing, you may see these changes in their blood count. Progressive thrombocytopenia, however, in severe disease is often a manifestation of disseminated intravascular coagulation, so DIC. So obviously this isn't a good thing to be seeing. And also decreased hemoglobin levels are reported in about 24% of patients and have been associated with bleeding in previous outbreaks.
So thinking about bleeding, Minnie, we could also, if possible, check coagulation studies to look at the clotting dysfunctions. A prolonged prothrombin time or activated partial thromboplastin time is associated with more severe infection and bleeding manifestations such as DIC, which you've just mentioned. Interestingly, patients with fatal infection have been found to have D-dimer levels, which are 4-fold higher on day 6 to 8 of infection compared with patients who survive.
An observation that means the outcome's going to be poor. So I suppose that gives you an opportunity to have those discussions with family and things.
Yeah, or also potentially start watching that person more carefully. Closely, yeah.
So the next battery of tests to think about are your liver function tests, and commonly these show elevated transaminases, so that's your ALT and your AST. And most studies do actually show that the AST rises out of proportion to the ALT. And this is more suggestive actually of systemic tissue damage rather than hepatocellular injury. A higher elevated ALT and severe jaundice can suggest a possible alternative diagnosis, for example, a viral hepatitis, and you may see your bilirubin, your gamma GT, and your ALP are often slightly elevated too. These abnormalities are just showing systemic severe illness, aren't they?
Yeah. Amylase may be elevated and indicates the presence of pancreatitis, which has been reported in several studies and again is an indicator of severe infection.
Talked about glucose. Hypoglycemia may be present in adults, but it's not that common, but it is much more common in children and may be severe. So, you know, we know hypoglycemia can present as confusion or reduced consciousness, and hypoglycemia is potentially reversible cause. And so it's really important to check your glucose regularly and treat it when you find it.
And then finally, you may want to do blood cultures. Negative blood cultures are helpful at excluding other non-viral infectious causes, for example, sepsis.
How are we actually going to manage them with Ebola, Fran?
So, Minnie, the first thing, obviously, is that Ebola disease is a notifiable disease. So it's really important that you notify the authorities.
Yeah.
But the mainstay of treatment is early recognition of infection, alongside effective isolation, which we've talked about, and optimized supportive care in a hospital setting. Infection prevention and control is immediately important, and local protocols should be followed. In previous outbreaks, they set up these Ebola centers for managing these patients. And if you go onto WHO, they've got pictures of how to set them up and the sort of flow through the centers.
Yeah.
To minimize contact and contagion. Patients who are identified as being at risk of infection, as per the case definitions, which we mentioned, should be immediately isolated, and PPE should be used until the infection is confirmed or excluded.
So interestingly, regardless of the causative species, the management of Ebola disease is the same.
That's interesting, isn't it?
Yeah, I mean,
and yet sorry, just as an aside, and we're going to talk about this later, there are therapeutics, but not for all three.
Yeah,
that's interesting.
It is interesting. So it just shows that the main management consists of supportive care for the complications such as hypovolemia, the electrolyte abnormalities, any of the hematological abnormalities, refractory shock, hypoxia, hemorrhage, septic shock, multi-organ failure, and DIC. And as you mentioned, Fran, you know, there are some therapeutics available for the disease that are caused by Ebola virus, but not for diseases caused by the Suzanne or the Bundibugyo viruses as yet.
As yet, yeah. Sorry to labour the point, everyone, but staff safety is so important.
And it is very much part of the management. I mean, that's the point, isn't it?
And, you know, already in this outbreak, there have been healthcare workers and doctors and nurses who have died. So it is incredibly important. So protecting healthcare workers is just as important as treating the patient. As you said, Minnie, laboratory investigations should only be performed when they're likely to influence management. Every blood sample taken creates a potential exposure risk for healthcare and laboratory staff, so investigations should be carefully selected and handled according to local and national protocols. And Obviously, where available, point of care testing is preferable because it reduces specimen handling, transport, and laboratory exposure.
Yes, similarly, Fran, clinicians should minimise invasive procedures wherever possible. So giving oral medications as preferred to intravenous therapies if the patient obviously can tolerate them, reducing the number of needle-based interventions required. When injections are necessary, avoid medications supplied in glass ampules if you can that require snapping opening, as this increases the risk of cuts and sharps injuries. I mean, it's just little things like that you have to think about, isn't it?
Yeah.
And for patients likely to require frequent blood sampling or intravenous fluids, early placement, if you can, of a central venous catheter, if it's feasible and safe, can reduce repeated venipuncture and minimises the risk of accidental needle stick injuries to staff.
Just to go back to your tip then, Minnie, essentially with every procedure, you should be asking yourself, will this benefit the patient? Can it be performed safely while minimising exposure risk to yourself and to other healthcare workers?
Yeah, absolutely. So we've put on the transcript a couple of links to some of the WHO guidance. One is on optimised supportive care for Ebola virus disease. So that's clinical management standard operating procedures, which they published in 2019. And then there's also quite a useful little pocket guide for frontline health workers on clinical management. So if you're interested, do have a look at those.
And that's 2016, isn't it? But not much has changed since then. Individualised and optimised supportive care is recommended for all patients. And we're just going to run through the key points and then go into some of them in more detail. So, Minnie, let's start with the systematic assessment and reassessment of patients. Going to assess vital signs, physical examination, fluid status and laboratory monitoring. You're going to record and respond to changes or abnormal clinical and laboratory parameters.
And you often see with these a sort of trend, don't you, in someone's illness?
Absolutely, yeah. You need to be recognising patients at high risk of complications, so you need to be assessing them more regularly, potentially every hour, and ideally have a staffing ratio of 1 clinician for up to 2 patients for these high risk patients. But for those not at high risk of complications, you can assess 3 times within 24 hours, so that's 8 hourly, to have a staffing ratio of 1 clinician for up to 4 patients.
Fluid resuscitation, always oral rehydration is recommended in patients who can drink, but often in Ebola this isn't possible, and then you're going to need to give IV fluids, and this is recommended in those who are unable to drink or who have severe dehydration, sepsis or shock. So basically, if you're so dehydrated that you can't keep up with the volume that you need orally, or you're seriously ill with sepsis or shock, then that's when you're going to move on to IV. And vasopressors may be required for shock if fluid resuscitation alone is not successful.
So you go do electrolyte and hematology monitoring and correction, so perform daily biochemistry tests during the acute phase of the illness on admission and as needed, and then manage the abnormalities as necessary.
So there's your caveat there of assessing whether or not tests are needed. They're going to change your management. Glucose monitoring and management, we've mentioned this. You check the serum glucose at least 3 times a day with the vital signs, and if someone's condition deteriorates, and manage with intravenous dextrose as needed.
You're going to manage potential co-infection, so you're going to give empirical antibiotics on admission with reassessment after 48 hours, and you're going to give empiric anti-malarial therapy until the malaria testing is negative or the treatment course is finished.
Fantastic. Nutrition, obviously very important. Encourage all nutrition if possible, provide enteral nutrition as tolerated, and consider IV dextrose in patients who cannot tolerate all food and have evidence of hypoglycemia.
Symptomatic care, and we'll talk a little bit more about this in detail. You're going to treat the fever, the pain, the nausea and vomiting, dyspepsia, diarrhea, anxiety and agitation.
And prevention and management of complications. This, we're going to try and prevent catheter-associated infections and pressure ulcers, manage complications, and we're going to talk about complications in more detail in the next part.
Yes, fantastic. So each patient should be assessed systematically using a suitable checklist. There is an example from WHO, and I've put that on the transcript if you're interested in seeing. As we mentioned at the start, you go check the vital signs, and we've listed those on the transcript, and perform a physical examination daily. And again, we've listed those on the transcript if you want to go through them and just remind yourselves of what things need to be done. And then you can also just tick off the daily assessment checklist.
Yeah, it's quite useful that actually, isn't it?
Oh, really useful, yeah.
And again, that's really going to help you see a trend in the patient's condition.
Yeah, and I think the thing is, why are we doing this? Because we want to identify those patients at high risk for complications,
Yeah.
isn't it, Minnie? Yeah.
Yeah. Identifying these patients, the sort of telltale signs are things like low systolic blood pressure, that's either in adults or in children, or delayed capillary refill time and cold extremities in a child.
And altered mental state or delirium or seizures.
Change in the vital signs, for example, tachypnea, so that's fast respiratory rate, a weak or rapid pulse, and a reduction in urine output, so oliguria. And this is defined as urine output of less than 0.5 mils per kilo per hour in adults and less than 1 mil per kilo per hour in children, or anuria, so that's producing no urine.
Which is incredibly worrying. Yeah.
So obviously you're having to monitor input and output of these patients.
Yeah, and as you mentioned with complications, that may be a catheter in patients who are unable to use the toilet or who are profoundly unwell, or it may be that you're just measuring when they go for a wee or weighing nappies, isn't it? You know, there are many ways in which you would monitor that. So you go look for hemorrhagic manifestations, so that's any unexpected bleeding, severe hypoglycemia, so a glucose less than 54 milligrams per deciliter or less than 3 millimoles per liter. Oxygen and oxygen saturations of less than 92%.
And then on your blood test, severe electrolyte, metabolic, or acid base abnormalities. These are signs of patients being seriously ill and at high risk for complications. Severe vomiting and or diarrhea, severe weakness with inability to ambulate, so walk around or stand up even, or eat and drink.
Yeah, these patients, you need to be looking at them, resuscitating them immediately and place them in an area of the treatment unit designed to care for the critically ill. So they need to be moved and they need to be having more intensive nursing care, don't they?
Yeah, absolutely.
Should we talk about fluids and electrolyte replacement just in a bit more detail?
I think that would be quite useful. Yeah, definitely.
Because this high frequency of vomiting and diarrhea means that these patients often very dehydrated and hypovolemic, particularly if they present late to healthcare settings. And that might be partly the reason for the high case fatality rates in outbreaks, as as the basic clinical monitoring is essential, but maybe hasn't happened, or it's difficult in resource poor settings, or the healthcare centre is so far away. There are many reasons why people are presenting late, isn't it?
Yeah. So one of the most important aspects of Ebola management is aggressive but carefully monitored fluid replacement. And we talked about this in our cholera course, and a lot of the principles are similar. Oral rehydration is definitely the preferred method, if possible, for patients who can tolerate oral administration and who are not severely dehydrated. But actually, the majority of patients require intravenous fluid replacement with either normal saline or lactated Ringer's solution, and the WHO recommends generally this as the fluids of choice. Fluid status, as we've talked about, Fran, should be assessed on admission at each visit or period of observation for shock and or dehydration. And a useful way to think about the fluid requirements is that they consist of two main components. One is the maintenance fluids. Now that's the patient's normal daily requirements, and there are some formulas to estimate those, and there's one on the transcript for you. And the second component is the replacement fluid component, and this is to compensate for ongoing losses from diarrhea, vomiting, bleeding, and insensible losses from fever.
We can monitor the input and output by recording daily weights, which is particularly useful in children, the total volume administered, so that may be oral or intravenously, and the total volume out. So again, urine, vomiting, stool, that all counts as volume out, yeah. You're going to weigh nappies, which I just mentioned, in uncatheterized small infants. And for example, urine and stool is a wet nappy weight versus a dry nappy weight. That's how you're going to figure that out.
Calculate that. For a febrile patient, this should be adjusted to account for insensible losses, which are approximately 2.5 mils per kilogram per day for each degree greater than 37 degrees.
That's so interesting. I think that's really useful.
So the volume of replacement fluid, we're looking at volume loss, and that's urine, stool, vomit, and blood loss, plus the insensible losses. And the replacement fluid for ongoing losses can be composed of either oral or IV rehydration. But the one thing to really remember that the cornerstone of supportive care in Ebola is the early recognition of fluid loss, aggressive replacement of deficits, and frequent reassessment. You're not just giving fluids, you're aiming to maintain euvolemia, prevent shock, avoid fluid overload, and support organ perfusion throughout the course of the illness. And on the transcript, we've just got a nice infographic from the WHO, which just reminds you about the definitions for mild, moderate, and severe dehydration and what you're going to find in your patients.
Brilliant. And we've also got, we've got quite a lot of information on the transcript that we won't necessarily talk through. We've got WHO guidance for the treatment of an Ebola patient with mild dehydration using oral rehydration salts. So, you know, if that's what your patient is able to do and you want to read it, please do have a look at the transcript. But, you know, as you said, Minnie, the majority of patients require IV fluid replacement, either with normal saline or lactated Ringer's solution. And options include a peripheral venous line, central intravenous route, if that's, as you said, Minnie, safe and available to you, or the intraosseous route if the patient is very collapsed. So, as you said, we're going to calculate how much people need, but just remember that large volumes of fluid are required, up to possibly 10 litres per day. Again, going back to the cholera course, isn't it? It's very similar. So that might be required in febrile patients with diarrhea. And we've got our third information about hydration is treatment of patients with severe dehydration. We've got another infographic then, again from the WHO.
Fantastic. Obviously, along with thinking about fluid loss, you're also losing your electrolytes, particularly when you've got severe diarrhea. So electrolyte monitoring is really important and should be performed daily and replaced as necessary. The electrolytes, that is, need replacing as necessary. More frequent monitoring can be considered if you're using large volumes of IV fluids or if you've got severe abnormalities in your biochemistry. Low and high potassium and sodium are often encountered due to dehydration or to fluid overload. Sometimes it's caused by the loss the patient is having, and sometimes it's caused by iatrogenic, by us giving fluids and not necessarily replacing everything that's being lost. So large amounts of potassium replacement, between 5 to 10 millimoles potassium chloride per hour, may be required.
You know, the WHO was saying you don't give that directly, you put that in the fluid that you're replacing them with.
Absolutely.
Okay, so just to say, Minnie, I mean, if it's available to you, you would also monitor for possible hypomagnesemia and hypocalcemia because these often coexist with the potassium and sodium abnormalities.
So we've mentioned before, hadn't we, blood lactate levels and how they can be used as a measure of hypoperfusion. And this can also help guide you in your fluid resuscitation.
So these patients, if you're giving someone lots and lots of fluid because they're very severely dehydrated, you need to be supervising them really closely because you need to be assessing their response, but also you need to be, like you say, preventing fluid overload. So you need to check for signs of shock, dehydration, or overhydration and be adjusting the fluid rate accordingly. That's measuring the vital signs and the volume status at least 3 times a day. These patients are at risk of shock. There is an infographic, again, WHO, going back to fluid management in sepsis and shock. Vasopressors are necessary when patients remain in shock despite adequate volume resuscitation. So that would be, for example, 30 mils per kilo in the first 3 hours in adults or 40 to 60 mils per kilo in the first 2 hours in children. So if they are still in shock despite this, and there are indications of fluid overload and there is no response to crystalloid resuscitation, then you would consider using a vasopressor, for example, noradrenaline.
Let's move on now to thinking about symptomatic management. In our overview, we briefly mentioned this, but what things can we give patients with Ebola when they have varying symptoms? So if we look at fever and pain, what can we give to aid those? Well, we can give paracetamol as a first line. If there's more severe pain, you can give opioid analgesic, for example, tramadol or morphine. Non-steroidal anti-inflammatory drugs, however, including aspirin, should generally be avoided because of their associated increased risk of bleeding and also for the potential of nephrotoxicity, particularly in dehydration.
Thinking about gastrointestinal symptoms, obviously we've talked about replacing fluids for diarrhea and vomiting, but diarrhea should be managed conservatively. You should not be using anti-motility agents. Don't forget that zinc should be given to all children with diarrhea. So in children under 6 months of age, that's 10 milligrams orally once daily for 10 to 14 days. And for children over 6 months of age, that's 20 milligrams orally, again, once daily for 10 to 14 days.
So for symptoms like heartburn, dysphagia, abdominal pain, it's quite a good idea to give a proton pump inhibitor, for example, omeprazole, or an H receptor agonist like famotidine. Analgesia can also help if someone's suffering from dysphagia, so that's pain on swallowing.
Brilliant. PPIs such as omeprazole should always be initiated as stress ulcer prophylaxis if you have a patient who is critically ill, because they're obviously at high risk of bleeding.
Mm-hmm.
For nausea and vomiting, you can use oral or intravenous antiemetics. The WHO suggests ondansetron or promethazine.
Thinking about co-infections, bacterial infections, and using empiric antibiotics, there are some guidelines on this. Empiric treatment with antibiotics is recommended for patients with Ebola virus disease on admission, with reassessment after 48 hours. Antibiotic management, including drug choice as well as dose, should be adjusted accordingly. Monitoring white blood cell count or other inflammatory markers like CRP can help assist in determining de-escalation of antibiotics. Obviously, you're treating empirically, aren't you? So you've got to decide when to stop.
Absolutely.
And it is not unusual for Ebola disease patients to develop new onset fever that may be associated with a leukocytosis, so raised white count, in the second or third week of the hospital stay. So often this can happen despite initial improvement in the presenting symptoms and the viral load. So in this setting, the development of a hospital-acquired secondary infection while on broad-spectrum antibiotics and the development of a resistant gram-negative bacteremia or C. difficile infection should be considered.
Hypoglycemia, we've mentioned this a couple of times. The serum glucose needs to be checked at least 3 times a day when the patient's vital signs are checked. So we mentioned that hypoglycemia is defined as less than 3 millimoles per litre or less than 54 milligrams per deciliter in adults and children in the context of Ebola virus disease. If you don't have a method to measure glucose but you suspect hypoglycemia, just give empiric therapy with dextrose. Let's be pragmatic about it, because in lots of these settings, people may not have these tests.
But it's quite likely, particularly in children.
But it's very likely, as you said, Minnie, very common in children.
Nutritional status is obviously something that we do need to think about, particularly when someone is seriously ill or has diarrhea and vomiting. Really helpful to assess on admission the nutritional status of all patients with Ebola, and what you're assessing are the patient's body weight, height, and in children you're going to measure the mid-upper arm circumference. Looking for signs of malnutrition is important, and assess the current appetite status. Despite someone being ill, you're going to really encourage them to take food orally, because patients need sufficient energy and essential nutrients in addition to fluid electrolytes. And if you have access to a nutrition specialist, that would be brilliant, and they can evaluate patients on a daily basis who have Ebola.
And just consider aiding someone's intake. So if they're not eating because they're feeling sick, then you use an antiemetic. If they're not eating because they're too weak, then maybe you use a feeding support, help someone to feed them, alter how they're positioned for meals and things. And if possible, you may need to insert an NG tube.
Now, seizures are uncommon in Ebola, but if they do occur, this is a sign actually of advanced disease, and they pose a real risk to healthcare workers, because this increases the risk of contact with the patient's body fluids.
Of course, yeah, it does, doesn't it? We do need to check for an underlying cause, don't we, in anyone who has a fit. So high temperature, particularly in children because of febrile seizures. Think about hypoperfusion, electrolyte disturbances. Hypoglycemia, which we've just mentioned, is a classic. So a benzodiazepine, for example, intravenous, intramuscular or rectal diazepam, can be used to halt the seizure. If there are recurrent seizures, then an anticonvulsant, for example, phenobarbital, could be given.
But obviously, if you find a cause, for example, hypoglycemia, you're going to treat that as well.
No, absolutely. Halt the seizure, treat the cause, yes.
Yeah.
Simultaneously.
Agitation, this can be associated with encephalopathy or possibly a direct effect of the virus on the brain, and can occur in advanced disease of Ebola. So you may want to use a sedative like haloperidol or benzodiazepine if it's imperative for keeping the patient calm and preventing sort of needle stick injuries in healthcare workers when you're trying to treat the patient. So this is a really difficult situation to be managing a patient who's agitated.
Absolutely. Respiratory distress, we mentioned briefly about maintaining oxygen saturations above 94%. So it's not just a question of putting oxygen on them. You need to evaluate them. Why is their oxygen low? Because it doesn't typically affect the lungs, does it, Minnie?
No.
But, have they got a hospital-acquired pneumonia? Have they been overloaded with fluid when you've been resuscitating them? Is there wheezing or congestive heart failure? And then obviously manage them accordingly.
I mean, also in sepsis, you're going to inevitably see a reduction in the oxygen saturations, aren't you? It can be a real sign of worsening disease.
Gosh, yes, indeed.
Bleeding, major bleeding actually occurs infrequently, but it is a manifestation of advanced infection and is usually, but not always, fatal. If you're able to, treatment will be giving fresh whole blood or platelets and plasma via transfusion. And you should do this in accordance with any of your local protocols and be guided by clinical and laboratory testing if available. We have put on the transcript the WHO guidance on bleeding, which is really useful because it's also gives you some other uses like tranexamic acid and vitamin K and that sort of thing as well, which are all good treatments.
So, Minnie, moving on, we hinted at, didn't we, that there is a specific treatment for the Ebola strain of Ebola virus, but there is no licensed vaccine or specific treatment for Bundibugyo or Sudan virus.
At the moment.
But I thought we should, at the moment, and whilst it's the Bundibugyo virus that is the current outbreak, this is of course on all Ebola viruses. So I thought we should just mention them. The therapeutics are antiviral monoclonal antibody therapies. So I'm going to try and pronounce these. So the first one has a very easy trade name of Inmazeb, and this is a combination, a cocktail of 3 different monoclonal antibodies, which are atoltivimab, mativimab and odesivimab, and it's also known as RGNEB3. And then the other one is called ansuvimab, which is also known as MAB114. So this is a single monoclonal antibody, and this is quite interesting. So this was initially isolated from the memory cells of 2 patients who survived the Ebola virus outbreak in Kikwit in 1995, and then maintained antibodies against the Ebola virus surface glycoprotein for 11 years after the infection. And that's how they manufactured this. Yeah, really interesting.
You're an absolute super patient, aren't you? You can provide.
I think you're invincible, aren't you?
Yeah. But providing treatment for thousands of people potentially from your antibodies is pretty amazing. Yeah. So the WHO strongly recommends these medications that you just mentioned, Fran, for patients with confirmed infection with Ebola virus. So that's the species, also Ebola virus, Zoonosis, and for neonates who are less than 7 days of age with unconfirmed infection who are born to mothers with confirmed infection of Ebola virus of that species. They have not yet been shown to be effective on other species of Ebola.
Both of these therapeutics work by binding to the glycoprotein of the Ebola virus, which is an essential component of the virus's structure and function. And this glycoprotein is responsible for the virus's ability to attach to and enter hosts. And I've put a picture of the viral structure there so you can see where the glycoproteins are.
Lovely. So the antibodies recognize and bind to a specific epitope on the Ebola glycoprotein, and this binding occurs with high affinity, so it's a really strong bond and ensures that the antibody can effectively neutralize the virus even at low concentrations. That is the key. Binding to the glycoprotein inhibits the ability of the virus to attach to the host cell receptors, so it's effectively blocking the entry of the virus into the cells, and this prevents the virus from replicating and spreading within the host, which is pretty cool, actually.
It's amazing, isn't it? So some additional information on ansuvimab. Now, it may be that the other drug does this as well, but I couldn't find any information on that. Ansuvimab also flags the virus for destruction by the host's immune system. So this process is known as antibody-dependent cellular cytotoxicity and involves the recruitment of immune cells such as natural killer cells, macrophages, and other components of the immune system that identify and destroy the antibody-coated virus particles. Additionally, it may engage the complement system, which is a cascade of protein interactions that lead to the lysis and removal of the virus.
Yeah, and another critical aspect of the ansuvimab mechanism is its ability to provide immediate passive immunity to the recipient, which is amazing. So unlike vaccines,
it is amazing, isn't it?
Because they obviously require time for an immune response and to produce antibodies, the ansuvimab delivers ready-made antibodies that immediately give you protection against the Ebola virus. And obviously this is really particularly important in an outbreak setting where the virus is spreading quickly and there's an urgent need for effective therapeutic measures. I mean, amazing if a new monoclonal antibody can be developed for the Bundibugyo.
It'd be amazing, wasn't it? Both of these therapeutics are given as IV infusions. They do have some common side effects. Greater than 10%, you are likely to experience fever and chills, often occurring during or shortly after the infusion. Tachycardia, so that's the fast heart rate, and tachypnea, a fast breathing rate, and gastrointestinal upset, so vomiting and diarrhea. However, just to remind ourselves, that's a bit tricky because they're also the symptoms of the Ebola virus itself. So it's hard to know if it's a drug side effect or whether it's disease progression.
There are some serious adverse events, as with all drugs, hypersensitivity reactions, severe infusion-related reactions, including anaphylaxis, sudden drops in blood pressure, and airway constriction have been recorded. And vaccine interference, the antibodies can neutralize live virus vaccines, such as the Ebola vaccine, which we'll talk to you about in the next part, which makes the vaccine ineffective if they're given at the same time. So that's just something really important to keep in mind.
Brilliant. So that's quite a lot of information, isn't it, about how we're going to manage these patients?
It is.
I found that really helpful. In part 3, we're going to go on and discuss immunity and vaccines, complications, prognosis, long-term sequelae, and possibly a case or two.
Brilliant. Thank you so much for listening.
And remember, you can download the supporting notes, complete the CPD quiz, and receive your certificate at www.horizonmedicaleducation.com. If you found this episode useful, please share it with your colleagues and follow us for weekly episodes.
Goodbye.